Hello, my name is Dr. Roxana Jabbar, and I'm going to be talking about the management of incidental thyroid nodules. These are one of the most common endocrine dilemmas that GPs face, and also one of the most common seen in the public face. So if you have a look around in social media, you will notice that some of the public reach out to some celebrities saying, "We can see a lump in your throat, you need to give us a call." And here we are talking about incidental thyroid nodules. We're detecting more of them is because we're imaging more. We do CT for trauma, we do MRIs for headaches, and we do carotid Dopplers. And suddenly there's a lesion. What do we do? It's important to note that even though detection has increased, mortality hasn't increased. So today this is about structured thinking, no panic, know how to do a referral pathway and know how to follow a diagnostic pathway. Just safe, evidence-based decision making, aligned with the British Thyroid Association and American Thyroid Association 2015 and 2022. So by the end of this session, you should feel confident about what an incidental thyroid nodule actually is, what genuinely increases the risk, what to do in a primary care setting situation, and how to interpret ultrasound reports. Also, when to refer. Don't jump to referral. When should we refer? And when reassurance to the patient is entirely appropriate, because most of these are benign. What is an incidental nodule? An incidental thyroid nodule is a lesion found on imaging done for another reason. It's incidental. Not because somebody felt a lump, they just found it accidentally. Sometimes somebody may see a lump, but it's incidental, it's just been noticed. Palpable nodules occur around 5% in adults. If you ultrasound the population, about 50% will have nodules. So very, very common. And malignancy risk is roughly 5 to 10% of these nodules. So it's a common finding, but with a relatively low cancer probability. And our job as physicians is risk stratification. When do we worry? We worry when there's rapid growth, when there's a voice change, when there's dysphagia or dyspnea. If they're not breathing very well and if they're having problems eating, we should be thinking about something concerning. If it's hard or fixed, or if the cervical nodes are also palpable. Now, the risk factors are whether there's a previous neck irradiation, so as a child or as a teenager that you've had some type of x-ray on the neck in that area, whether there's a family history of thyroid cancer, and of course, MEN type 2. Any age, well, age I would look at should be under the age of 20 or over the age of 70. When there's no red flags, we just need to stop and slow down and think. You feel a lump and it's really concerning, and they may have some red flags, they may not have some red flags. Well, what do you do straight away? Well, the best thing to do is TSH, so thyroid stimulating hormone level, always, because thyroid stimulating hormone or TSH changes the pathway. Now, if the TSH is low, think hyperfunctioning nodule. Low TSH, request an uptake scan. If the nodule is hot, malignancy risk is extremely low. If the thyroid stimulating hormone is normal or high, request a neck ultrasound. Do not order an isotope scan if TSH is normal. TSH will direct you. So get a TSH first. Let's do a case example. A 52-year-old woman has a CT after a minor road traffic accident. She's got pain in her neck and they just want to check her neck out. And then you have an incidental finding of a 1.6 centimeter thyroid nodule. She feels well. She's got no voice changes. She's got no swallowing difficulties. She's got no family history of any problems, and she's got no previous neck or radiation exposure. And her examination is unremarkable. Now, what would you do? There's nothing to worry about. She hasn't got any red flags, but the easiest step is to check her TSH, and it comes back normal. Next step, ultrasound. Ultrasound report on a 1.6 centimetre nodule comes back. It's got smooth margins, it's isoechoic, it's got no microcalcifications, there's no abnormal lymph nodes. So it's classified as a U2. What's that? Let's talk about the management. So this is not an urgent referral. No biopsies required. It's just a case of reassuring the patient. Now let's change one variable in this. So same patient, but the ultrasound shows irregular margins, microcalcifications, and it's hyperechoic genicity. Now we're on U5. This is when I would refer very urgently. It's the same size, but it's a completely different morphology. So there's a completely different management. So I mentioned U2 and U5. Well, I weren't talking about the bands or music bands. It's interpreting the ultrasound. So in the UK, we use U1 to U5. So U1 to U2, that's benign. U3 is indeterminate. U4 to U5, that's where you think suspicious. Look at the descriptions. Irregular margins, microcalcifications, taller than wide shape, for example, much taller than it is wide. Abnormal lymph nodes. These are all things that are going to make you think of managing this patient in a completely different way. Look at the size. Size alone does not determine the risk. It's the morphology that does. So when would you refer? Well, urgent referral, it's obvious, U4 to U5. If there's suspicious nodes, if there's voice changes, or if there's very rapid growth. Routine referral for indeterminate nodules will be needing an FNA, which is a fine needle aspirate. Benign appearing nodules without any red flags are often just safe to monitor. So structured assessment will reduce that anxiety. Managing the benign nodules. Most nodules are going to be benign, and management of these nodules is really reassurance, monitoring if it's appropriate, and treating any thyroid dysfunction if present. Levothyroxine suppression therapy is not routinely recommended, and sometimes the most evidence-based things you can do is explain probability clearly. So in summary, incidental nodules are common. Most are benign. Thyroid stimulating hormone directs the pathway. So a low TSH, you ask for an uptake scan. Normal to high TSH, get an ultrasound. Look at the ultrasound and look at the morphology, which will then guide referral. Follow a structure. This reduces a lot of anxiety in patients, and in fact, it reduces a lot of anxiety for practitioners. Practice defensible medicine.